by Professor Chan. I have been looking forward to this all day. Regional anesthesia in obese.
Good afternoon. You notice that I've switched to a Mac so that there won't be time off and I'm not under a lot of time restraint. I'm asked to talk about regional anesthesia in obese patients. I don't know why you need to know that, because when I look around I don't see many people as big as this person. So whatever you're doing here is good, so keep up, do the exercise and eat the right diet. I think it's good. I also don't want to only talk about my colleagues in United States. You notice that this is a Canadian flag, so we do have big people in Canada as well. So what I want to do is to look at some of the issues regarding regional anesthesia in obese patients. I have the same disclosure as this morning. Yes, obesity becomes an epidemic in North America. I, again, don't see too many big people or obese people here. According to the World Health Organization, when a BMI is over 30, obviously that is considered obese. There are different classes. And for bariatric surgery, we do quite a lot of laparoscopic bariatric surgeries. We routinely see patients in the class 3. So on one hand, we know these patients have many coexisting diseases, and some of them are very good if we can do regional anesthesia. For example, many of them may have obstructive sleep apnea. We don't want to use the minimum amount of opioids. They may have difficult airway. We don't want to instrument the airway if possible. And they are known to have a higher respiratory complication after general anesthesia. So for all those reasons, we would like to give them a regional anesthetic technique. But having said that, we know it's going to be a challenge, right? You and I have the experience when we need to put a needle into an obese subject, an obese patient. Oftentimes it's more difficult. It's difficult because we cannot palpate, we cannot see the external landmarks or internal landmarks. And it's more difficult to position the patient when they are so big, particularly if they need to go in a lateral decubitus position. And obviously we have to use the right equipment, maybe a longer needle in order to reach the space. So this is not my patient, fortunately. I got it from the internet. I think the picture comes from the Society of Obstetrics Anesthesia in the US. And of course it is very difficult. Doesn't matter how strong you are, your thumb is not going to feel the spinous process. And this obviously becomes an issue. Trying to put an epidural or spinal in this subject will be difficult because, again, we have poor landmark to guide us. And if you are going to do this in a lateral decubitus position, it will be so difficult. The tissue is going to be always coming down, and you have to fight. So sitting up is a good way to do a spinal and epidural in this patient. So I was looking at the literature and see if there is anything we can do to locate the midline without ultrasound. Obviously, this is something else, something simple, something that we can use. And this is in the obstetrics patients, and they look at for neuraxial block. They have in this study they have 64 morbidly obese patients, and they asked them to just use their thumb and point to the midline, just a single attempt. And in fact, the anesthesiologists find that whatever the patients show them is actually quite reliable, help them to locate the midline. Another way they look at it is they will use the thumb, the anesthesiologists use the thumb or something light to stroke across the back and tell the patient to tell them to stop when they think that's a midline. Again, that seems to be working in some of those patients. For peripheral nerve block, obviously, again, it's a struggle. If you want to do an X-ray block here, you will have a hard time feeling for the pulsation. And if you want to feel for the interscalene groove here, again, it will be a big challenge. So again, the lack of easily identifying landmark will be a problem. And it's a major problem to put the needle in. So since we have these challenges, Does that mean we are going to take longer to do the procedure? Does that mean the success rate is going to be lower, higher failure rate? And also, what about complications? Will we end up having more complications if we do regional anesthesia in those patients? And also, would they come back to the hospital unanticipated? So again, I check the literature and see what it shows. I think realistically, we don't need the literature to tell us, right? For first and the second, of course, it's going to take longer. I mean, there's no brainer. The success, of course, is going to be a little bit lower than a routine case. So I think those are quite straightforward. But just to show that I'm scientific, I went to the literature and say that this is before ultrasound time. This is in the Duke hospital in the Duke, over 9,000 blocks in close to 7,000 patients. Yes, the failure rate is higher when the BMI is greater 30. That's 12.7 versus normal weight 10. So even in a very high-class regional anesthetic center, at that time is still about 10% failure rate. But for those patients who have a successful block, this is important. No difference in the pain at rest as expected, but also no difference in the incidence of unanticipated hospital admission. Another study, I said to you, my friend Carlo Franco, he's very good with supraclavicular block before ultrasound, and yes, the failure rate is about 3% greater, but he was not able to see any difference in complications. This is again a peripheral nerve block, X-ray block in patients who are just going to have the landmark approach. As the body mass increases, you'll see that the incidence of failure increases. And also the vascular puncture rate is greater in the obese subjects. So this is one that shows the complication rate with vascular puncture is greater. This study concludes that obesity is not a significant independent risk factor for unanticipated admission. It's quite interesting. Most of the patients underwent general anesthesia. They have a high failure rate. I hope that my hospital does not see this. 22% unanticipated admission rate for the control group, and of obese group 26%. One thing that is more interesting is intra-op bronchospasm, PAC oxygen supplementary rate, and also post-op nausea and vomiting are both all greater in the obese subjects. What about neuraxial block? Many of the obese studies on obese subjects belong to the obstetrics patients. This is again before ultrasound time. Most of the blocks were spinal anesthetic, and the difficulty with finding the place with palpation and also difficulty with puncture is extremely high, about 30%. The moderately obese to very obese, high rate. But notice that the block failure rate is only about 2 to 3%, fortunately. And yes, it will take longer to do the procedure. One other thing to remember is, since it's not only a challenge to us, but also a challenge to the surgeon, it will take a longer surgical time. So that means we have to time our anesthetic well to match the longer surgical time. Now this is looking at obesity on neuraxial block, again on pregnant ladies, and look at whether the obesity is a predictor of technical difficulty. And they look at two important factors. One is how easy it is to palpate the spinous process, and secondly, how much the patient can bend the back in flexion. And what they conclude is obesity per se is not directly predict difficulty. And it's true, you and I know some patients are very big, very heavy, but it's mostly in the front, not in the back. And the back you can still feel the spinous process. But when it's difficult to palpate the spinous process and the patient cannot bend, then the number of needle attempts increases. So I think we don't really need the literature to tell us, yes, Usually the procedure time is longer, the success rate usually is a bit lower, and then complications, there is some evidence that, particularly vascular puncture, it is greater. This one, look at the use of ultrasound now. Does it really improve? Does it improve our success rate in obese subjects? And this one, look at interscaling block in different people with different sizes, and in the obese subjects, all these things are increased. Increase in the insertion of the needle as expected, and this study put everybody to sleep, so they were not able to look at clear success rate. But looking at the post-op pain and the use of opioid, that probably suggests that patients did not have as good a block as the other patients. This is quite interesting. They look at catheter insertion using ultrasound, and they were not able to show the difference between obese subject putting in obese subject versus non-obese. Both are very 7 minutes. So this group of investigators obviously are very good. They are Dr. Mariano at that time was at University of California, San Diego. But notice that all the catheters were placed in a rather superficial area, interscalene, infraclavicular, femoral, and popliteal. I think if you ask me to put a catheter in this lady for sciatic nerve block, I think it would be probably a different story because it's going to be deeper, it will be more challenging. So I think it really depends on what type of block we're talking about. I think for spinal and epidural, clearly ultrasound, you have heard about it. You notice with the ultrasound, all we are going to see is this shadow. This is the spinous process. In obese subject, obviously, it's going to be much deeper, but yes, we will still see it, and that's the beauty of the ultrasound. What we do is, again, we're not doing a real-time ultrasound-guided block, not like the peripheral nerve block, but we map it. So we can map the spinous process at different levels and mark it. Then we look at the interspace to look at this window. You heard about the lines inside. So all it is if there you can see inside, you can see the lines, that means there must be a window. That's all it is. It's actually easier to scan the back than peripheral nerve because you don't need to identify anything. Whether you see lines or no lines. If you see lines, there must be a window. And also, the distance from the skin to the dura is an estimate because particularly in someone who is big, you're going to use a lot of pressure to push in order to get an image. So artificially then the distance from the skin to the dura is now compressed into shorter. So the actual distance should be greater. After we have identified that, we will put the markings, and now we have an x-axis, y-axis. Remember to remove all the gel from the skin because we don't have any neurotoxicity data for the gel introduced in the neuraxial space. And when we make a mark on the skin, wipe off all the gel, and then do the procedure as the usual fashion. So again, this is a guide. It's not going to exactly precise, but if you can see a space there, that means there must be a space. You don't have to keep. If you cannot get it on the first and second attempt, doesn't mean that you have to switch to another level because there is a space. It's just maybe you're off the midline a little bit. There are a number of studies, mainly from the Toronto group. My colleagues at Mount Sinai, they look at the correlation between the depth determined by ultrasound with the needle depth. Again, very, very similar, looking at the distance here. They also look at it transverse versus power median. No surprise, they correlate very well. Again, it helps you to determine how far to go in. And more importantly, is there a space there? If there is a line that you can see, there is definitely a space at that level. And we also want to prove that it is ultrasound is helpful, so we purposely look for big individuals and also patients with scoliosis, with previous laminectomy, and we're able to demonstrate that with ultrasound scanning, we can decrease the number of attempts. So this is a a good sign. Okay, remember when we use ultrasound, there are also difficult to see the nerve targets. Okay, so this is difficult. Don't expect that ultrasound is going to be easy, because with ultrasound, particularly with high frequency, there will be dropout artifacts because the signal is going to be diminished with time. So don't expect that you can see very well. That's why we use the compensation, the gain compensation, to help us. So the message is use the lowest frequency in order to get the penetration, but when you do that, the image resolution, the image quality will be less. Needle, again, is going to be difficult to see. So that is why we use the echogenic needles. So I think that if we are going to do a regional anesthetic technique, we have to use proper techniques. I will not choose a deep technique, a deep block. I would rather go for superficial approach. I think that would be a wise thing to do. So my message again is, yes, ultrasound can do a lot of things, but ultrasound, when you want to image very deep in obese subjects, can be a big challenge. Thank you.